Welcome to this morning's webinar for the Andrology Research Academy. My name is Dr. Adrian Heald. I'm chairing this meeting today. I'm aware that people have dialed in from all over the world, and I welcome you to this webinar. Today we're going to discuss the past, present and future of testosterone deficiency in diabetes. For me, I'm based in Salford in the UK. I'm a clinical endocrinologist. I'm also a senior lecturer at Manchester University with a particular interest in male health and within that in relation to the cardio-metabolic features of testosterone deficiency and how we can address those. I have received support from a number of pharmaceutical companies over the years, but do not have any conflicts of interest in relation to this morning's webinar. The aim of the Andrology Research Academy is to provide an educational platform that, as we've said in the slide here, will enable a forum for educational exchange, to enable sharing of the latest research in the field of andrology, and to foster interaction with international experts. And the seminar that we'll hear today is including two of the greatest figures in the field of andrology in 2021. We're grateful to Predominant Healthcare for sponsoring this webinar and this site that hosts the Andrology Research Academy. The aim of the Academy, and of course of the webinar today, is to ensure that all of you have the most up-to-date knowledge in relation to male health and management of androgen metabolism and androgen function in the context of that, so that all of you and all of us can make the best treatment choices for their patients. The aim of this webinar specifically is to refresh and strengthen our understanding of the relationship between testosterone and type 2 diabetes. We know that many men with type 2 diabetes and also with pre-diabetes do have testosterone deficiency, and there are significant consequences of that both in the short and the longer term. Our speakers will review and appraise the current evidence based on the important role that testosterone therapy and lifestyle factors can play in improving diabetes outcomes and improving male health in general. And we will be discussing and sharing evidence-based pragmatic ideas and approaches that importantly can be incorporated and included into routine daily practice for all of you, so that all of us can do better with our patient care and ensure that our patients have the optimal outcomes. So just some technical points before we go into the webinar itself. You'll be looking at the moment on the left-hand screen. If you wish to go to full screen, then please do press on the double arrows. However, in order to ask questions, you need to go back into the left-hand screen, and in order to do that, please do press escape in your screen format. So in order to go to the chat to ask questions, you need to press escape and then go into this screen. And then in the right-hand box, you can type in your questions, which will then be made available to me as chair at the end of the webinar, so we can have a live discussion with both speakers, both Hugh and Mattis, in relation to what they've talked about today. So please do use the chat facility so that we can then have plenty of questions at the end to ask our speakers. And in order to exit the chat box, you then go back to the double arrows to go into full screen. At the end of this seminar, we'd greatly value your evaluation. There's an evaluation button that will appear at the top of the screen, and you'll receive an email after the webinar if you're able to complete the evaluation with a certificate of attendance. So please do evaluate the webinar today. It's really important as we move forward to have your feedback as delegates in relation to how we've all done today. So the programme. We've had the opening remarks from me. The first speaker is my colleague, Professor Hugh Jones from Sheffield. He was going to talk about insulin resistance and testosterone. What do we know and what can we do about it? We'll then go on to hear from Mathis Grossman, who's already in evening time in Melbourne, about testosterone, lifestyle factors, and the recently published, hugely important landmark T4DM study. I will then tie up with some concluding remarks and some take-home messages before we go into a 15-minute question and answer session. And in order to have questions heard at that session, you'll need to input your questions into the chat box. So that's our webinar today. I'm going to hand over now to my great colleague, Professor Hugh Jones, who is going to talk to us about diabetes, insulin resistance, and testosterone. What do we know? Over to you, Hugh.
Hello, I'm Professor Hugh Jones. I'm a consultant physician and endocrinologist at Barnsley Hospital, an honorary professor of andrology at the University of Sheffield in the United Kingdom. I'm today going to talk about diabetes, insulin resistance, and testosterone. What do we know? As this is a fairly complex area, I'll go into some detail. So this is where I come from in this University of Sheffield and Sheffield Hospital and the Barnsley Hospital. And Sheffield is famous for the Krebs cycle, because that's where the Krebs cycle was originally discovered. So there is a link between this talk and the Krebs cycle. So these are my declarations of funding. So type 2 diabetes in the world is becoming a pandemic in its own right. And this is a projection from the International Diabetes Federation as to what diabetes would be like in 2025. And this was made back in 2010. And you can see that there are very high levels of diabetes throughout the world, with very high levels within Africa and Asia. The next slide shows, however, this is from Nature Reviews back in 2011, looking at the projection of not only diabetes in blue, these are different countries in the world, but also of impaired glucose tolerance and not diabetes, so pre-diabetes. And you can see that there is a significant number of patients in each country who will have impaired glucose tolerance, so pre-diabetes. So this is very important to understand that the quite significant amounts throughout the world. So you've got, these are the lower numbers in these columns are the prevalence of diabetes. And above that, you've got the increase in diabetes from 2010 to 2030. So you've got between 20 and 98% increases, so quite dramatic. So what is diabetes? Diabetes is an impairment of the body to deal with glucose and also fats metabolism. This is a cartoon to show this is the development over a 4 to 7 year period from impaired glucose tolerance to frank diabetes, with diagnosis of diabetes on the dotted line. So what we see first here is the insulin resistance, which is the key biochemical defect in type 2 diabetes. So this gradually increases over the pre-diabetes phase and becomes persistent over the diabetic phase. And along with that, you start to get an increase in insulin levels, but it gets to a point round about the time of diagnosis of diabetes where insulin levels start to fall. And this is due to damage to the beta cell of the pancreas, which gets damaged by both lipo and glucotoxicity. And also we see around the time of before the diagnosis of diabetes that the liver starts to increase its glucose production. So the key things about diabetes are also the increase in plasma glucose. So the dotted green line is the increase in fasting plasma glucose, and the orange line is postprandial glucose. And this gives us the diagnosis. But we must be aware that the complications, both microvascular and macrovascular, occur in the pre-diabetes time period. So the major complications of type 2 diabetes are microvascular and macrovascular, as I've said. So the microvascular are retinopathy, so a high number of patients will end up with impaired vision. Nephropathy, 21% of diabetes patients end up with kidney disease and death, and this includes type 1, this figure. Then 70% die within 5 years of amputation due to foot problems, which are a combination of micro and macrovascular disease with neuropathy and peripheral vascular disease. And along with the macrovascular complications are stroke, impaired blood flow, dementia, macrovascular disease of the heart, causing heart attacks, angina, heart failure. But we also know that erectile dysfunction is very common in type 2 diabetes, with up to 70% of the population having the condition. And ED may be the first sign that someone has got, or signs or symptom, as well as that someone has got vascular disease, because a third of men with ED will have their primary problem will be low with narrowing of the penile artery. And this can give you a herald, if you like, for future development of a major adverse cardiovascular event within 2 to 5 years from developing ED. So we have this iceberg effect, which is well understood, that you have diabetes above the waterline, but below the waterline you have this metabolic syndrome, pre-diabetes. And some people can have it for 10 to 15 years before developing full diabetes. And this includes atherosclerosis, pro-inflammatory and pro-thrombotic changes, hypertension, dyslipidemia, glucose intolerance, hyperinsulinemia, insulin resistance, which I've mentioned, and abdominal obesity. So these are the key factors. And they actually, the diagnosis of metabolic syndrome based on the IDF or other NSEP classifications include abdominal obesity, the sugar impairment with the hyperinsulinemia, the hypertriglyceridemia, and the low HDL cholesterol, and high LDL cholesterol. Hypertension as well. So this is cartoons which might help people understand a bit more about insulin sensitivity, that subcutaneous fat is insulin sensitive, unlike central fat. So this is John, who has only a little subcutaneous fat at the age of 20, and it's mostly in his arms and legs. And this is insulin sensitive, stores free fatty acids well, and it also takes up glucose easily. He only has a small amount of central fat, which is poor at storing free fatty acids and not very good at taking up glucose. But as he gets older and he eats, has lack of exercise, he develops obesity. And this subcutaneous fat stores, they actually become full, bursting, and they're not so good at taking up the excess glucose. He's laid down a lot of central fat, and it's the central fat which then becomes present in the pancreas and also the liver. So in the liver, it leads to reduced adiponectin, and this is associated with increased insulin resistance. And adiponectin is an important hormone which switches on insulin sensitivity in body tissues. Increased fat is toxic to the pancreas, so this leads to the reduction in insulin, which I've told you about, and accelerates beta death, as well as the high glucose also stopping the beta cells working. The central insulin fat can't take up glucose very well and regurgitates free fatty acids. This leads to diabetes and abnormal lipid levels. The insulin-resistant fat secretes peptides, which contribute to hypertension, inflammation, and atherosclerosis. So visceral obesity, and this is a study from 1997 which looked at glucose disposal against the amount of visceral adipose tissue, and this was total subcutaneous. And this is for men and women. Men are in red, and there is this relationship that the greater the amount of adipose tissue, the worse your glucose disposal. Although subcutaneous fat doesn't seem to appear to make a significant difference. So the components of the metabolic syndrome appear to be related to testosterone levels. And the more components you have, this is 1, 2, 3, 4 to 5, the lower your testosterone. And also the relative risk of hypogonadism, of having a total testosterone of less than 8, is linked to the number of components of metabolic syndrome. We know we have a high prevalence of hypogonadism in type 2 diabetes. This was a meta-analysis back in 2006, which looked at various studies looking at testosterone levels alone in diabetic cases compared to healthy controls. And on average, a diabetic has almost 3 nanomoles per litre of testosterone lower than the healthy control. This is a study from my unit. We looked at 355 men with type 2 diabetes, a mean age 58, an age range between 32 and 83, and we showed that the prevalence of hypogonadism, that is biochemical evidence of deficiency as well as symptoms, was 17% in this population, and below 12 nanomoles per litre, 42%. So approaching half of patients with type 2 diabetes have hypogonadism. And we can see here, this is yellow is less than 8 and red is less than 12. And you can see that it does increase with age. And we have in that population a very close link between waist circumference and testosterone. The higher the waist circumference, the lower the testosterone. This study looked at a group of men who were normal, insulin glucose intolerance, and diabetes. And what it showed was that the lower the testosterone was associated with a reduced insulin sensitivity in here. And also there was a parallel reduction in VO2 max, and an enzyme called UQCRB expression was also lower with lower testosterone, so indicating that there's a link between low testosterone, insulin sensitivity, and mitochondrial function. So how may this happen? This study was looking at men who were already on testosterone, and they stopped their testosterone treatment for 2 weeks. They had idiopathic hypogonadotrophic hypogonadism, a congenital classical form of hypogonadism. And it was seen after 2 weeks that the mean fasting glucose level rose, and also the fasting insulin level rose. So this was a short-acting effect of testosterone withdrawal, which is part of the picture that we will see against some patients, the majority of patients with diabetes having a longer effect of testosterone, low testosterone on their insulin sensitivity. So what is insulin sensitivity and resistance? What does it mean? Well, insulin sensitivity equates to glucose disposal rates, uptake, and utilization. Insulin resistance is impaired insulin action and reduced glucose disposal. It's measured by HOMA-IR in larger populations, and this is based on the fasting insulin and glucose. There are 2 equations, HOMA-IR1, which is this equation, fasting plasma insulin times fasting plasma glucose divided by 22.5, which actually correlates well with the hyperglycemic, hyperinsulinemic euglycemic clamps. The HOMA-2-IR is a computerized model. Both correlate with each other, but HOMA-IR reads slightly lower. This panel here shows that insulin resistance is a higher risk factor for cardiovascular disease or events as smoking. We see here, this is the HOMA-IR, and this is in people with without metabolic syndrome against people with metabolic syndrome, which shows this effect of HOMA-IR1 and HOMA-IR2, and HOMA-IR2 not reading as high. This panel here shows where insulin resistance is placed in the development of heart disease, and it is an intermediary cardiovascular risk factor. It's genetic, visceral obesity and lack of exercise leads to this insulin resistance, which causes the high glucose, hypertension, dyslipidemia, thrombotic risk, and microalbuminuria, which is a marker of endothelial dysfunction. All factors which then lead to increased CV risk and atherogenesis. So this is how insulin resistance sits into this picture. This is the first study on insulin resistance in type 2 diabetes, which came from my unit, which shows that what we did was a randomized placebo controlled crossover study. So initially patients had testosterone for 3 months. There was a washout period, and then they had placebo, or vice versa, placebo first, then testosterone. And what we showed is that the HOMA-IR improved on testosterone here. And the HbA1c also showed a slight improvement of about 0.37%. Right, this is the Moscow study. It's looked at the effect of testosterone and decanoate, long-acting intramuscular injection, on insulin resistance in hypogonadal men with metabolic syndrome over a 6-month RCT period with 184 patients, so a large study. And this study showed that the HOMA-IR with testosterone fell with these patients from baseline, and this is the treatment arm, and this is the placebo arm, and this was significant. The insulin levels fell, but they did not approach significance. Glucose levels did not reach significance, but we know that glucose levels are very labile in patients with diabetes. This is looks at the Moscow study looking at waist circumference in this panel, and we see that there's a significant reduction in waist circumference. So there's this link between insulin resistance and visceral adiposity. This was the ×2 study, testosterone and metabolic syndrome in type 2 diabetic patients. And this was a study throughout 8 countries in Europe, with 220 patients, and it was an RCT testosterone gel versus placebo over a 12-month period. And what we saw was an improvement in insulin resistance after 6 months, and the blue is the treatment arm, and grey is placebo. And this benefit persisted for up to 12 months when the study was complete. This shows the changes between HOMA-IR and HbA1c between the different cohorts. This was all patients, type 2 diabetes and metabolic syndrome patients, and you can see here that in all these graphs, there's an improvement over placebo of the insulin resistance as measured by HOMA-IR. The HbA1c rose in both groups slightly over the first 6 months, but then started to fall in the treatment arm at 6 months. And it became significant 9 months in the diabetic patients, but didn't reach significance in the metabolic syndrome patients. It was in the second 6 months that primary care physicians were allowed to change the diabetic dose. However, there was no differences in treatment between these two arms, and this suggested a benefit on HbA1c, which was late. This looked, the ×2 looked at body fat composition, and this is percentage body fat. And what we see in the metabolic syndrome patients is a significant reduction in fat percentage, as well as the type 2 diabetic population. The waist circumference improved in the metabolic syndrome patients, but in the diabetic patients it didn't reach significance, and that was because several diabetic patients were not obese. This study came out in 2016 in Diabetes Care, which used the hyperinsulinemic euglycemic clamps, which are the gold standard for performing insulin sensitivity. It is very time-consuming, and only a small numbers of patients can be incorporated in the study because of the time restraints. So this was a fairly large study in this respect. It was 44 men with hypogonadism and type 2 diabetes. And what this showed was using the glucose infusion rate, the CLAMP study, that there was a significant improvement in insulin sensitivity after 24 weeks of testosterone replacement therapy compared to placebo. And this was also correlated with HOMA-IR and showing this reduction, showing that there is a parallel reduction in these two parameters compared to placebo. The BLAST study looked at HbA1c. Here what we have is a 30-week RCT of testosterone and decanoate long-acting testosterone injection against placebo. And we see these are severe patients with testosterone, severe hypogonadism patients with testosterone less than 8 nanomoles per liter, mild hypogonadism 8.1 to 12. And what we see, no difference at that 30-week period. However, after that, we get a significant reduction in the open label study in the patients already on testosterone, showing this late effect on HbA1c. This is not as apparent, but it is in the mild hypogonadism, but it does reach significance. The HbA1c open label study, which was poorly controlled diabetics, this is taking out those with poor controlled diabetes, showed no significant difference at 30 weeks, but at 82 weeks we see this 0.71% reduction in HbA1c. Again, this late response. This was the GROTE study, which was published in 2018, again with testosterone and decanoate, and we have HbA1c and HOMA-IR. And we see in this group, which was a study which was 1 gram of testosterone every 10 weeks for 12 months. And we see a significance in drop of 0.94% in the HbA1c at 12 months, not at the 6-month period. And we see the testosterone effect on insulin resistance, a significant benefit. So the meta-analysis of 15 trials of testosterone substitution in hypogonadism, and we see in this study that the fat mass reduces, lean mass increases. And we also see that the HOMA-IR increases, and there's a fasting glucose which significantly falls. There was a approaching significance reduction in cholesterol and triglycerides. And from this study, they did a sub-analysis which showed that lean mass was important in the reduction of HOMA index and fasting hyperglycemia. And the fat mass was not associated. So this was a slightly different to what we've been finding in other studies in this meta-analysis. This is a registry study which was published last year in Diabetes, Obesity and Metabolism, which is an 11-year follow-up study which compared a group of men who were untreated as the control group compared with those in the black line treated. In the green line treated, sorry. The black dotted line is the difference between the groups from baseline of 0, and we can see that there is that there was not much difference at 1 year, although it was approaching significance, but became more significant as time progressed. And this also was apparent for HbA1c, that we know that if you don't, that there's this deterioration of time in HbA1c over the follow-up period compared to, and then we have this benefit of testosterone. And this is the same spec we have on waist circumference and also BMI, so matching it quite nicely. So HbA1c is important. An increase in HbA1c of 1% can lead to a 21% increased diabetes-related death increase, an increase of 14% of MI and 43% of peripheral vascular disease. And this was from the UK PDS study. So the use of HbA1c in diagnosis of diabetes and prediabetes is important to understand. So we know prediabetes has a cutoff of 5.7%, for above that level for pre-diabetes, and for diabetes above 6.5%, 48 millimoles per mole. But data suggests you should use the oral glucose tolerance test and fasting blood glucose for the diagnosis, especially of pre-diabetes and in any borderline for diabetes at the top end of the pre-diabetes range. And this is because this is a study which shows that the HbA1c over this range doesn't seem to increase with fasting blood glucose until it's up towards the 6%. And similarly for the 2-hour glucose tolerance test. So glucose uptake and utilization, there are studies which show that testosterone improves the expression and activity of key stages in glucose uptake. So we have the insulin receptor here, and we have the GLUT4 receptor. So when the insulin receptor is stimulated, the GLUT4 receptor comes from out of its vesicle and translocates to the membrane. And we know that testosterone increases the expression of parts of the insulin receptor, as well as also enhancing the GLUT4 translocation to the membrane. And we have also, and others have also shown that testosterone increases the expression of GLUT4 and also the key control enzymes of glycolysis, which is glucose utilization, which is hexokinase 2 and phosphofructokinase. It also increases glucose conversion to glycogen, and also increases the glucose utilization down the nucleotide synthesis pathway. It acts on the mitochondrial oxidative phosphorylation to increase the rate of oxidative phosphorylation, the Krebs cycle. So we have knowledge from in vitro study that testosterone is acting at different sites to increase glucose uptake and utilization, which are the key factors for insulin sensitivity. So in conclusion, insulin resistance is a central biochemical defect in pre-diabetes and type 2 diabetes. Insulin is a key intermediary CV risk factor. Testosterone replacement in hypogonadal men with pre-diabetes and type 2 diabetes improves insulin sensitivity. Effects on glycemic control take time to show benefit and are more evident in severe hypogonadism. The main benefits of testosterone therapy become evident after 12 months. HbA1c is a less sensitive monitor of glycemic control in men with pre-diabetes and glucose tolerance. So any benefit on glycemic control and reduction in the progression of diabetes is very important for reduction in complications of diabetes, including mortality. Thank you. I'm just going to give you a mini advert. We're conducting a worldwide audit of testosterone and diabetes, and this is by the Association of British Clinical Diabetologists, ABCD, and anyone in the world can actually register for this study, and they can put their own patients on and actually audit their own data, but their data is also then accumulated into the world data amount and be able to analyze what is happening to these patients in large numbers to give us more idea on the benefits of testosterone treatment in hypogonadal men with diabetes. And this is the website where you can go and find out about the audit and also register. Thank you very much.
Thank you, Hugh, for that comprehensive evaluation of the metabolic aspects of hypogonadism in men, both with and without type 2 diabetes. And Hugh, I think that's about the best explanation of insulin resistance that I've ever heard. So thank you very much for that great talk. And we will be giving you some questions and discussing your presentation a little later on. So now moving on to Professor Mathis Grossman, who's speaking to us today from Melbourne. As I mentioned, Mathis has been a leader in terms of leading investigator on the T4DM study, recently published, that he's going to talk about. Mathis is going to talk about testosterone, lifestyle factors, and the landmark T4DM study. Over to you, Mathis.
So thank you for this introduction. As mentioned, I'm Mathis Grossman from the University of Melbourne in Australia, and the title of my talk is Testosterone, Lifestyle Factors, and the landmark T4DM study. In terms of disclosures, I have received research support and speaker on AReA from companies marketing testosterone products, among others. So the outline of today's talk, I'll start out with definitions, making the important distinction between organic and functional or late onset hypogonadism, make a plea for a holistic treatment approach, and then focus on testosterone treatment trials with the focus on men with either diabetes or obesity, i.e. diabesity. So in terms of definition, male hypogonadism, as you will all be aware, is a clinical syndrome comprising androgen deficiency, the focus of this talk, and or infertility, and the diagnosis requires both consistent clinical features as well as a clearly low testosterone. Functional hypogonadism is defined as the coexistence, not necessarily causal, of both androgen deficiency-like features and low serum testosterone that occur in the absence of both intrinsic classical organic HPT axis pathology such as Klinefelter's or pituitary tumor, and of specific pathological conditions that could suppress the HPT axis, such as microprolactinoma or Cushing's syndrome. Organic hypogonadism is due to proven structural HPT axis pathology, such as Klinefelter's or pituitary tumor. It's generally irreversible, presents with specific features, and testosterone concentrations are consistently and severely low. It is underdiagnosed, and testosterone replacement is the undisputed treatment of choice. By contrast, functional hypogonadism lacks recognizable structural HPT axis disease, is therefore a diagnosis of exclusion, and at the same time, importantly, has potential for reversibility. It presents with non-specific features, and testosterone concentrations are often only borderline or fluctuate around the lower limit of the normal range. LH tends to be typically low or normal because of the strong association with obesity and comorbidities. Optimization of weight loss and comorbidities is the first-line approach, while the long-term risks and benefits of testosterone therapy have not been fully described. I just wanted to start off with a case that I've seen only a couple of months ago, which was a 67-year-old man who was actually referred to the respiratory physician for optimization of his obstructive pulmonary disease and complained about back pain, had an X-ray which showed a clear fragility fracture and found to be osteoporotic. So the respiratory physician did a secondary screen which showed severe primary hypogonadism. Clinically, the diagnosis was Klinefelter's. He had several previously ignored or not investigated fractures. He had a history of infertility as typical, and he reported that since starting testosterone treatment, he was generally much happier and had an improved quality of life and muscle strength, and the karyotype confirmed Klinefelter's. So this is a sad story, but not uncommon, because organic hypogonadism tends to be underdiagnosed. In Klinefelter syndrome, the most common cause thereof, only a third of men are diagnosed in their lifetime, and even if they're usually diagnosed relatively late, around the time where they might present for infertility in their 20s, although it can be as late as our man in his 60s, despite the fact that the diagnosis can be easily made on physical examination, exposing these men to potentially unnecessary increased morbidity and mortality. So my take-home message number one is to think of hypogonadism in men with unexplained psychosexual complaints, osteoporosis, anemia, and sarcopenia, because testosterone treatment in these men has not only striking benefits on physical appearance, but also on sexual function, energy level, hemoglobin, bone density, and body composition, except, of course, on fertility. Now, by contrast, the concept of late onset hypogonadism, the most common cause of functional hypogonadism, with a prevalence by stringent criteria of approximately 2%, rising to 5% in men older than 70, that concept stems from the observation that on the one hand, serum testosterone declines gradually during male aging, and on the other, aging and hypogonadism have overlapping features. Because the largest testosterone RCT to date has randomized only 1,000 men for 24 months, questions regarding causality and long-term hard clinical outcomes of testosterone treatment still remain. Just to highlight the significance of the problem, and Hugh Jones has similar data from the UK. A low testosterone in men with diabetes or other comorbidities actually very common. You can see that in an unselected cohort of consecutive men attending diabetes outpatients, 57% had a low testosterone, with a mean testosterone approximately 2 nanomoles per liter below the reference range. And these diabetic men who had a low testosterone also had an adverse metabolic phenotype, in that they had increased prevalence of obesity, insulin resistance, dyslipidemia, and a pro-inflammatory state. And in these men, again, Hugh Jones has similar data, and this was work done by A. Timp, and she was a fellow in our group. Low testosterone is a very powerful predictor of mortality. So if your free testosterone, and similar results apply for total testosterone, is clearly normal, above 230, your chance of being alive at 10 years is 90%, whereas if your free testosterone is clearly low, less than 160, your chance of being alive is less than 40%. And this is independent of a variety of confounders. Of course, observational studies can by design never prove causality. It is possible that these findings are due to non-causation, causation, or reverse causation. There is some evidence that the age-related decline in serum testosterone is actually not necessarily caused by, but at least accelerated by accumulation of age-related comorbidities. So healthy aging without weight gain and chronic disease tends to drop testosterone only very slowly, whereas this is can be markedly accelerated by development of obesity and incidental comorbidities. And there's some cross-sectional data that reports no age-related decline of testosterone in selected men from Australia reporting excellent health. So it is clear that at the very least, modestly low testosterone in older men is commonly a marker of ill health. So in a given clinical scenario, therefore, it is not always clear whether it is the obesity and the chronic disease that is driving symptoms and organ deficits and mortality, at the same time causing HPT axis suppression akin a Hypogonadal syndrome, or whether and if the low testosterone contributes to the clinical picture, and if so, to what extent. So given this uncertainty, certainly it is important to approach functional hypogonadism holistically. So that may consist in lifestyle measures and optimization of chronic disease, which has the potential to reverse the functional HBT axis suppression. You could focus on treating the predominant clinical problem, or in the right context, consider offering testosterone treatment, and we go through these options in turn. So what is the evidence for lifestyle measures and optimization of chronic disease? Obesity is the strongest risk factor for low testosterone and LOH, decreasing testosterone by 30% compared to lean, and increasing the prevalence of LOH, so symptomatic testosterone deficiency, by 13-fold. And it's therefore not surprising that obesity is the strongest predictor of receiving testosterone treatment in US men. Importantly, from a therapeutic perspective, weight loss in obese men can lead to marked increases in testosterone concentration that tend to be proportional to the degree of body weight lost. And as a rule of thumb, you can take home that 10% weight loss, which is achievable by lifestyle measures, in some cases can increase testosterone by approximately 3 nanomoles per liter, whereas bariatric surgery territory weight loss can increase testosterone by 10 or more nanomoles per liter. Moderate exercise has evidence to improve functional hypogonadism associated end organ deficits. It may improve erectile function additive to phosphodiesterase 5 inhibitors and increase circulating and muscle androgen concentration, and exercise should therefore be recommended routinely. So as a take-home message, it is important to motivate your patients by telling them that successful weight loss combined with optimization of comorbidities, although difficult in practice, has the potential to improve symptoms, normalize serum testosterone, and improve overall health in men with functional or late onset hypogonadism. So what about treatment of the predominant clinical problem? And I just highlight sexual dysfunction as a common clinical scenario. While it is difficult to directly compare across different clinical trials, you can see that in terms of erectile dysfunction, phosphodiesterase 5 inhibitor treatment consistently exceeds the clinically important minimal difference, whereas testosterone treatment tends to have more modest effect on erectile dysfunction, as has lifestyle modification. However, sexual function is not just about erectile dysfunction, and I should highlight the T trials or testosterone trials that have shown that testosterone treatment modestly but significantly improves 10 out of 12 sexual domain functions, so has a broader sexual effect than phosphodiesterase inhibitor in some cases. What about testosterone treatment? And here, as mentioned, I will focus on men with diabetes. Again, to remind you, we focus on men with type 2 diabetes initially because of the frequency by which testosterone is low, with studies from Australia, Hugh Jones in the UK, and in the US suggesting that about 40 to 50% of men with type 2 diabetes have a low testosterone. So Emily Giannotti did a clinical trial in 90 men as part of her PhD, which with admittedly well-controlled diabetes and an HbA1c of 7.0%, but to our surprise, despite showing the expected metabolically favorable changes in body composition with an increase in muscle mass and a decrease in fat mass, testosterone treatment had no effect on any measure of glucose metabolism, whether HbA1c, HOMA-IR, or the OGTT-based insulin sensitivity index, and did not improve hypogonadal symptoms as assessed by the aging male symptom score. Erectile function, if anything, was significantly worse in the testosterone group, certainly not better. And in these men, interestingly, their baseline symptoms correlated with increasing age and comorbid burden, not with their serum testosterone, suggesting that it's really comorbidities in age that drive both low testosterone and symptoms rather than low testosterone driving those symptoms, at least in older men with relatively long-standing diabetes in the study of average 10-year duration. We followed this up with a meta-analysis. Admittedly, this was a low number and men had fairly well-controlled diabetes at baseline, but the results show that in men with established diabetes, testosterone treatment had no effect on HbA1c or on hypogonadal symptoms assessed by the aging male symptom score. So, coming to obesity now, we were interested in this self-perpetuating cycle between low testosterone and obesity because on the one hand, weight loss increases testosterone, while on the other, testosterone treatment reduces fat mass. So Mark Ng, as part of his PhD, did an RCT in obese men with lower serum testosterone. Men were randomized 1-to-1 to testosterone and placebo, and all men participated in a rigorous structured weight loss program to test the hypothesis that testosterone treatment has benefits on body composition and hypogonadal symptoms over and above the effects of a caloric restriction alone. Here are the outcome results, and you can see that while testosterone treatment did not have an effect on body weight loss, which was quite marked after 56 weeks in both groups, losing approximately 11% of kilos, so no difference in body weight. However, men in the placebo group lost both fat mass, which is desirable, as well as muscle mass, which is undesirable, whereas the testosterone treatment-related weight loss was practically purely of that of fat mass, suggesting that testosterone treatment prevents the caloric deficit-associated loss of muscle mass and instead favors loss of fat mass. And of note, men in the testosterone group also lost more of the metabolically adverse visceral fat, although this trial was not designed for glycemic outcomes. And in these men, despite the fact that they were not selected on the basis of hypogonadal symptoms, in contrast to the older men with established type 2 diabetes, in these men, testosterone treatment did improve strength, hypogonadal symptoms, erectile function, and increased libido. And as mentioned, those men were not selected on the basis of symptoms, but if you group them on the basis of their baseline symptom score, as you would intuitively predict, the symptomatic improvement in the testosterone treatment was progressively more marked in those men who had more severe baseline symptoms, exceeding the clinically meaningful change in men with moderate to severe baseline symptoms. Of course, again, this might not be expected. Testosterone treatment, when stopped, loses its efficacy. So you can see that this is the time on testosterone treatment, that at 18 months post-study exit, baseline weight had reverted back towards baseline, and the benefits in body composition that were seen at the study end, at the end of testosterone or placebo treatment, 18 months after treatment was ceased, were no longer evident, suggesting that testosterone treatment would need to be continued long-term, safety provided. Now, how do we reconcile these disparate findings between the two trials? One hypothesis that we have is akin to the timing hypothesis in menopausal hormone therapy in women, so that if you are an older man with established diabetes, a large comorbidity burden, the specificity of hypogonadal symptoms declines and you're less likely to respond symptomatically to testosterone therapy because the symptoms are driven predominantly by comorbidities. At the same time, in end-stage diabetes where there's insulin deficiency, testosterone may not have metabolic benefits. Whereas on the other hand, if you have a younger man with pre-diabetes or the metabolic syndrome with less comorbidities, the potential to respond to testosterone treatment intuitively should be higher, and insulin resistance might be reversible. So this was further supported by the outcomes of our meta-analysis, where I already showed you the data that, with the caveats of low numbers, it appeared that testosterone had no effect on glycemic control in men with established diabetes. There was a modest improvement in insulin resistance measured by AReA in men with pre-diabetes and the metabolic syndrome. So this data and hypotheses were directly tested in T40M, a large multi-center Australian clinical trial under the leadership of Professor Gary Witt from Queen Elizabeth Hospital in Adelaide. And I thank Gary for allowing me to present the data and show some of his slides. This trial tested the primary hypothesis that testosterone treatment will reduce the incidence of type 2 diabetes in men with low testosterone over and above the effects of a lifestyle program alone. And this study has just been published in the Lancet Diabetes and Endocrinology with an associated commentary that you might like to read in your time. So we tested the hypothesis that testosterone treatment over 2 years will prevent progression to or reverse newly diagnosed type 2 diabetes in high-risk men concurrently enrolled in a community-based lifestyle program. Key secondary hypotheses that where the testosterone treatment for 2 years will lead to metabolically favorable changes in body composition and improve sexual function. It was a multi-center Australian clinical trial. Inclusion criteria were a high risk of diabetes based on an OGTT, i.e. pre-diabetes, or a new diagnosis of type 2 diabetes with an allowed 2-hour glucose up to 15 nanomoles per liter. Serum testosterone had to be less than 14 because of epidemiologic evidence that below that concentration, diabetes risk increases steeply. Exclusion included organic hypogonadism and other potential confounders or contraindications to testosterone therapy. All men were enrolled in a lifestyle program administered by Weight Watchers. Study treatment was injectable testosterone or matched placebo according to standard schedule. Men were randomized in a stratified fashion, and we calculated that we needed 1,000 men for the 2 co-primary outcomes. Number 1 being the ability to detect a 30% relative risk reduction in type 2 diabetes incidence based on the OGTT 2-hour glucose over and above the effect of the lifestyle intervention alone, and also be powered to detect a reduction in the second co-primary outcome, the 2-hour glucose of 0.6 nanomoles per liter between the groups. Baseline characteristics, not surprising, obese men in the late 50s, 80% of pre-diabetes, 20% diabetes. And interestingly, you can see that the screening serum testosterone at around 10 was much lower than that of the gold standard LCMS-MS that was remeasured, batched at study end, suggesting that the commonly used clinical assays, immunoassays, are not that reliable, especially at the lower range. The follow-up was pretty good, 80 to 90% for a 2-year trial. So here's the primary outcome data. So you can see that 21% of placebo treated men developed diabetes at 2 years compared to 12% of testosterone treated men, for a risk ratio of 0.59 or relative risk reduction of 40% that persisted after adjustment for baseline factors. At the same time, there was a highly significant between group difference in the mean change of 2-hour glucose of 0.75 millimoles per liter. Interestingly, there was no relationship between the serum baseline testosterone and the treatment effect, suggesting that this was a pharmacological effect. In addition, while there was a trend, but not significant, of more body weight loss in testosterone treated men, testosterone treated men had a significant larger loss of waist circumference, less loss of muscle mass. Testosterone treated men had an increased loss of fat mass, of abdominal fat, and improved grip strength. In testosterone treatment compared to placebo, also improved all assessed measures of sexual function. There were more men in the testosterone treated group that normalized it to our OGTT blood glucose, while there was no difference in reported use of antidiabetic drugs, compliance with lifestyle program, or self-reported sufficient weekly exercise. Of note, testosterone treatment also decreased the fasting glucose with a between group difference of 0.17 millimoles per liter. Although interestingly, and we might come back to this in the discussion, there was no effect on HbA1c. The most common safety trigger was that of an increased hematocrit occurring in 20% of testosterone treated men, although of those, only a quarter, so 5% of total, had hematocrit concentrations of more than 54 on repeat testing and were excluded from the study. Despite the size of the study, as you would expect, this number of serious adverse events were relatively low, with no significant difference between the groups. So in summary, we've shown that testosterone treatment in high-risk men decreases the relative risk of diabetes at 2 years by 40%. Beyond the effects of a lifestyle program alone, it is a pharmacological effect associated with favorable changes in body composition and grip strength. It has modest benefits for sexual function. Cardiovascular safety was reassuring, although underpowered. The most common side effect was an increase in hematocrit, with 5% ceasing treatment. So therefore, it is important to assess for risk factors such as sleep apnea before considering prescribing. The results of the trial cannot be generalized beyond the relatively low-risk population enrolled, the concurrent lifestyle program, and the frequent monitoring and support. And overall, as mentioned before, a holistic treatment approach is important, and men will best be served with a comprehensive and personalized approach to healthcare that includes a thorough assessment of their physical and physiological conditions and risk factors, and aims to optimize health-related behaviors. So my take-home messages then are firstly that organic hypogonadism is underdiagnosed and testosterone replacement has marked benefits, so think of it in the right clinical context. In older men, lower testosterone is often a marker of poor health, and their functional HPD axis suppression may be reversible by implementation of lifestyle measures and optimization of comorbidities, although difficult to achieve. It should always be tried, while finally more research is required to determine the long-term hard clinical outcomes of testosterone treatment in older men with functional hypogonadism. So with that, I thank you for your attention.
Thank you very much, Mathis. We rarely hear about a study that can potentially change practice worldwide, and the T4DM study is undoubtedly a study that is going to raise questions in terms of how do we go about the screening, but the results are very powerful in terms of indicating the benefit in relation to treatment of hypogonadal men who have prediabetes to prevent many of them going on to develop diabetes itself over a particular time frame. So thank you, Mathis, and obviously we'll come back to you with some questions. If I could just ask the audience, please, if you do have any questions, to put in the chat box. After my brief talk, we will be going into the discussion for 15 minutes. So, as I said, I work in Salford in Greater Manchester. I've been working in the area of hypogonadism, particularly in relation to metabolic health, for more than 10 years now. And I really would just like to put some questions to you in terms of how we can move forward from here. We're certainly not advocating that all type 2 diabetes men should receive testosterone therapy. As Mathis has said, there is a very significant role for lifestyle modification in terms of exercise, more healthy eating, looking at portion sizes, people being aware of their weight and the impact on a whole variety of features of their health, including their testosterone level, their androgen status. So lifestyle factors are important, but sometimes pharmacological treatment may well be necessary. The international guidelines currently recommend screening men for type 2 diabetes who have type 2 diabetes for testosterone deficiency, especially if they have erectile dysfunction, which, as Hugh has indicated, is a harbinger not only of potential hypogonadism, but also of cardiovascular disease as it affects the penile arteries. And based on the T4DM results that we've just heard, I would advocate that it's entirely reasonable to add pre-diabetes men, in other words, men with non-diabetic hypoglycemia, to the list of men who should be screened at intervals for the presence of hypogonadism. In Cheshire, in the UK, where I also work for a small amount of the time as a diabetologist, we have only just published some guidance, some up-to-date guidance taking into account all of the recent developments in diabetes therapy. And within that guidance, we have advocated that men with prediabetes, taking up the findings from the T4DM study, and also type 2 diabetes, should be screened every 3 years and treated with testosterone if necessary, while also bearing in mind the influence of lifestyle measures. We've heard that low testosterone levels occur in over 40% of men with type 2 diabetes, and that this presence of hypogonadism is associated with an increased mortality over and above the elevated mortality rates that go with having type 2 diabetes mellitus, and importantly, that testosterone replacement therapy in hypogonadal men with type 2 diabetes has been shown to reduce mortality. Very important. So it is absolutely worth treating these men, not only in terms of their quality of life, but also their longer term health prospects. Furthermore, we have heard that in men with hypogonadism and prediabetes, testosterone replacement therapy can prevent progression to type 2 diabetes mellitus with a relative risk reduction of 40% over the follow-up period of 2 years. And importantly, there is associated improvement in metabolic profile. So it goes back to the point that I've made. It's good practice. We would advocate to check a morning testosterone level in men with prediabetes and with type 2 diabetes at least every 3 years. Just wanted to present a couple of things from our own group that we've looked at. Firstly, we did an audit published in the International Journal of Clinical Practice last year of the actual testing and recommendations that are given with regard to the matter of assessing androgen status in men as a whole. So this isn't about just type 2 diabetes men, but men as a whole. And what we found, as you can see from the slide here, was that there is a significant variation between the laboratories, not only in the platforms that they use, but also in the cut point that they would apply to define hypogonadism, anything from 5 nanomoles per litre up to 11 nanomoles per litre across the laboratories, which are all working within the National Health Service, all NEQAS accredited laboratories in the United Kingdom. So there's quite a lot of variation in the message that's going out there to primary care, to doctors, to nurses, to patients in relation to what hypogonadism is. And that leads us to the point that I'm going to put to Matthias and to Hugh about, well, what should be the cut point? We know that if you use an LC-MS method, a physical method for measuring testosterone, that will give a higher equivalent cut point for the definition of hypogonadism than an immunoassay. And as Matthias said, the results between immunoassays can be quite variable, not only in terms of what people recommend with the immunoassay, but also what the immunoassay results show. We know that from the T4GM study that the pharmacological effect of testosterone is not related to baseline serum testosterone concentrations. That's something else that we need to bear in mind. But the question is, at what point should we deem a man to have hypogonadism? That's something that in the UK we are working on. And at the moment, even within our National Health Service, which is a publicly funded healthcare system, there is, shall we say, significant variance in the recommendations that are put out by laboratories, which actually does not help people who are out there in primary care particularly, but also in hospital environments, trying to make a diagnosis of hypogonadism when we know that actually hypogonadal men treated with testosterone will do better. And just a word about fasting testosterone. This is some work that's actually in press at the moment that we've done. This is in one laboratory in the West Midlands with my colleague Mark Livingston, who is a professor of biochemistry in the West Midlands. And we looked in a very carefully curated group of people, making sure that there was a reasonably short length of time between the fasting and non-fasting testosterone measurements, that there was nobody who was actually being treated with testosterone. So these were men who's had their natural testosterone level measured. We compared the fasting with a non-fasting testosterone within a 6-month period, ensuring that they were taken, the samples have been taken at a similar time of day. And as you can see from the plot here, that if we look at the non-fasting testosterone versus the fasting testosterone, there is absolutely no trend whatsoever. We cannot say that the fasting testosterone level is consistently higher than the non-fasting testosterone level when we actually look in a carefully curated sample of men. So take-home message is that actually we would advocate that there is no need for men to be fasted for a measurement of their testosterone level. It's not convenient. We're moving away from fasting tests for a whole variety of things, including lipids and glucose. And while perhaps in a perfect world of a laboratory environment, there may be validity to measurement of a fasting testosterone, we have stated very clearly on the basis of evidence that a fasting testosterone is not necessary. So you can just take a random morning blood sample, ideally between 8 and 9 a.m. In whatever time zone you are. But importantly, there's no need for the person to be fasting. So it needs to be morning, but does not need to be a fasting sample. So that work is in press at the moment, but is, I think, an important contribution to our discussion today. So, take-home messages. Going back to the substance of these talks, we know that low testosterone levels occur in over 40% of men with type 2 diabetes, and we, in our own work, have shown that levels of testosterone adjusted for age are significantly lower in type 2 diabetes men than in type 1 diabetes men. We would very clearly advocate that all pre-diabetes and type 2 diabetes men have a check every 2 to 3 years of their morning non-fasting testosterone level. It is so important in terms of the management of metabolic health in all of the population, but particularly in people with pre-diabetes or type 2 diabetes, that we address lifestyle factors, and that involves diet, exercising, avoiding high-calorie snacks, keeping portion sizes low. In addition, where appropriate, in obese individuals with type 2 or with pre-diabetes, and also non-obese individuals if they're hypogonadal, that there is consideration given for adding testosterone therapy. But particularly when it comes to those people who are obese or overweight, we know that actually they can potentially lose weight, as shown eloquently by Hugh in the studies that he described, and that will have significant knock-on effects, not just for their metabolic control, but for their overall mortality risk. We know that improvement in glycemic control is very important for reduction in complications of diabetes, reduction in mortality rate, and it is therefore really important that we bear in mind always in our management of people with pre-diabetes and type 2 diabetes the importance of assessing their androgen profile, their androgen status, acting if they are hypogonadal, not just addressing lifestyle measures, but also adding in testosterone replacement to improve their health outcomes as they go forward. And of course, as always, these patients need to be followed up. They need to have monitoring of their testosterone level, monitoring of their full blood count, monitoring of their prostate-specific antigen. So we have some clear take-home messages there that follow on from the talks that we've heard today. It is very important that you now have an opportunity to ask questions, and we're now going to move into the discussion section that I will chair. So I'll just see what's come up on the chat box here in terms of any questions. I think a question for both Hugh and for Mathis is there any correlation between total testosterone and total vitamin D level in the studies that you have done? So this is a general question about the studies that you've been involved with over the last 20 years. Is there any correlation between total testosterone and vitamin D in these studies?
So I can answer that. In our studies, we haven't specifically looked at this, but there are studies that suggest that there's a direct correlation between testosterone concentrations and vitamin D concentrations, but this could be confounded by obesity. There's some experimental work that testosterone and the vitamin D pathway interact with each other mechanistically, but whether this is true and relevant in humans is not known.
Hugh, any comments? Can you unmute?
Sorry, I was saying I agree with Mattis on these points. Vitamin D correlated with low testosterone is in several studies in the literature, but we haven't specifically measured vitamin D in our studies. So otherwise, I agree.
Okay. So moving on, we've had a question about, actually, as I've alluded to in my brief piece, about the point at which hypogonadism should be defined. I'm sure that's a question on many people's minds. Of course, many clinicians on this webinar will be sending their samples to laboratories that have an immunoassay rather than an LCMS technique. But I'd again ask both of you, please, to comment, starting with you with regard to at what point should we define hypogonadism. Mark and I obviously did the audit. We showed significant variation in what's recommended by our labs across the UK. So the cut point, where should it be, please? Thank you.
Well, firstly, it's trying to be sure that the assay that is used in your laboratory is got reasonable correlation with the LCMS assay. We use the Siemens assay, and that is very well correlated. So I think it's important, if you have a good assay, you can use that safely. Otherwise, the guidelines, as I'm on the European Association of Urology Guideline Committee, does state a cutoff of 12 nanomoles per litre. However, it's important that that is based on symptoms as well as the testosterone, and you need 2 levels at least a week apart. And most guidelines state that if you have these parameters, you can give a trial of testosterone replacement therapy for at least 6 months, and that will see whether or not the patient individually is improving on the symptoms, and that is key. I think it's very important, though, for symptoms in diabetes, and I find this, is that any improvement in erectile function and also libido can take longer than 6 months at times, so you need to treat diabetic patients for a bit longer. There are lots of differences that have occurred adversely in the penile tissues and the mechanisms of vascular dilatation, nerve function, fat deposition between the tunica albuginea and the corpus cavernosum, which leads to venous leak, and also the tissues within the tunica change from elastin fibers to collagen. So these are not going to change overnight, and they take time. And this again underlines the importance, I think, when you're treating patients, the benefits you get, especially for the metabolic side of things, as well as the weight loss, actually exceed 12 months usually. And most of the studies we've done, apart from this new study with the T4D, have been short term in those respects of 3, 6, and 12 months. So unfortunately, we need longer term studies to see these improvements. But coming back to the diagnosis, I think if a patient comes to see you about a problem, they are concerned about their well-being, their marital status, their relationships, and they're feeling rubbish. There's a reason why they've gone to see the doctor. So this is without screening, and therefore, if their parameters of low T below 12 nanomoles per litre and they have symptoms, they do warrant a trial of replacement therapy. And I think that's a general thing throughout most international guidelines.
I certainly support that view. Matthias, what's your view on this in terms of the cut point?
Yes, I think the important point that you made is that hypogonadism is a clinical diagnosis which is then supported by reduced serum testosterone concentrations. And the latter point is equally difficult than the clinical assessment because all the symptoms and signs can be very non-specific. So the best data suggests that there was a big harmonization study where 10,000 men were measured with a CDC, so Center of Disease Control, certified LCMS assay, and in the young men, the lower limit was about 9.2. That's for young, healthy men. And so that could be, if you have a LCMS or at least an assay that is standardized towards an LCMS that traces back to a CDC standard, that could be the lower limit of reference range for young men. There's some debate whether there should be an age-adjusted reference range or not. So in other words, for older men, should there be lower serum testosterone concentrations? There, for example, are data from Australia looking at men with excellent health. And in their 70s or 80s, the lower limit for those men was about 6. So you could argue that there's an age-dependent gradient in serum testosterone. So in younger men, a lower testosterone is more suspicious of hypogonadism in the right clinical context than in older men.
And I would certainly support the premise that it may be in future we will move to an age-banded range in the way that we do for insulin-like growth factor 1, which of course also does in many people decline with age. Yeah. So I think everyone's question that you've kind of raised yourself, Mattis, is in terms of this matter of the HbA1c in the T4DM study and why you didn't see a fall with HbA1c. Obviously, your starting HbA1c wasn't that high anyway, so you alluded to that in your presentation. Would you like to just expand on that now, please?
Yes. The problem with testosterone and HbA1c is that testosterone stimulates erythropoiesis. So there could be an effect of testosterone on red cell lifespan. So if you actually measure HbA1c, you might underestimate the glycemic benefit. So this is data we're currently looking at in secondary outcome papers from the T4DM study. So potentially testosterone could longiten red cell lifespan, which would then lead to a falsely increase in the HbA1c.
Okay. Any thoughts, Hugh, from your point of view on what Mathis has said?
No, I agree with Matthews on that. That's absolutely a possibility. But I did mention in my talk about the HbA1c at the lower levels being not as accurate and reflecting the fasting glucose. So I think there are a lot of factors involved here which need to be ironed out. The World Health Organization do not recommend HbA1c as a diagnostic tool for the diagnosis of prediabetes, and that is dependent on oral glucose tolerance testing after a fasting blood glucose. And in their data, they say it's 25% sensitive in making that diagnosis. So that proves the point that at those lower levels of HbA1c, maybe up to 6%, that it is not a good measure. I mean, when we have all these large diabetes studies for new diabetes drugs, the criteria are that the HbA1c is greater than 6.5 or even 7%. So then you might get benefit. And I think in some of the studies which have been published in the field of testosterone and diabetes, it's those where they have a higher starting HbA1c, which have shown falls. There was an early paper from Bulgaria which did show that, and those were on, and also a paper on naive patients, not on any other drugs for diabetes. I think diabetes is very complex. You can't class everyone with the same type of diabetes within type 2 diabetes, and it's heterogeneous population, and we all have those patients within clinic. Whatever you do with the classic treatments of diabetes, they do not, their HbA1c doesn't fall. So you've got people who are resistant and you've got those people who are sensitive, and a spectrum between the two. So as per any diabetes studies, they use several thousand patients usually, and that was the beauty of the type T for D study, is it used 1,000 patients at least. So this is the largest study. Prior to that, we only have studies up to N numbers of about 220 as our times 2 study. So really in type 2 diabetes, we need that class of study, that format of study with a large number of patients who are poorly controlled, and then see what the benefit is. But my concern also is that it takes time for testosterone to improve insulin sensitivity, reduce weight, and you may get those benefits, as we've seen in the registry studies, after 12 months. So really, we need longer-term studies. There is one study that's taking place currently in the United States, which is treating men. It's called a Traverse study. It's treating men over 4 to 5 years. There's a cardiovascular outcome study, and there may be, and that N number is going to be about 6,000. But how many of those will have diabetes will obviously depend on recruitment, and that might help. And that will be reporting, I think, in 2024-ish time, dependent on recruitment and outcome events.
And a question from me to both of you. You've spoken at length about the benefits in terms of glycemia with regard to testosterone treatment, and also on insulin resistance, also on waist. We've heard a lot, those of us who do diabetes, about the SGLT2 inhibitors and how they have these effects on reducing cardiovascular events, improving renal outcomes in the case of canagliflozin, perhaps for the others as well. How do you see the kind of benefits of testosterone mapping up against the benefits of the GLP-1 analogues, the SGLT2 inhibitors? Do you see that those benefits should be synergistic, stroke additive, or another relation? In other words, we know that these SGLT2 inhibitors, GLP-1 analogues, are good for cardiovascular risk reduction. How do you see that testosterone would the effects of testosterone in the hypogonadal man would interact with those effects?
Well, I think the important point you made is that for testosterone treatment, we do not have equivalent hard clinical outcome data. So we do not have hard outcomes on cardiovascular events or renal events for testosterone treatment, which is obviously a matter of the field not being quite as developed as in the bigger trials that are used for SGLT2 and GLP-1 inhibitors, etc. Whether there's a synergistic benefit, that's a speculation. It's possible that the mechanisms are different, but no studies exist that have either proven or disproven this fact. But it's an interesting hypothesis that needs to be studied.
Thank you.
From my perspective, that the study we did, that we published in European Journal of Endocrinology on metabolism, and we showed that the effect of those on testosterone replacement therapy actually converted a hazard ratio of 2.2 for death back up to the normal line for a diabetic with a normal testosterone level. There's registry studies and there's also epidemiological studies which have shown significant benefit and halving the death rate. And I feel with that that is hard, Devon. I know it's hard data, but it's data that we haven't had, yes, from RCTs, but those studies have not been longer. So should we wait? There are several studies now showing safety with large studies epidemiologically. I think one of the issues also is that we have to be very as clinicians, if we're replacing testosterone as we do with thyroid hormone replacement, we have to replace it to the normal range. And sometimes I see that doesn't happen. And there was a study from Sharma in European Heart Journal, which clearly shows that if you normalize the testosterone level, you get benefit. If you give testosterone and you don't follow that patient and monitor, and they do not reach a satisfactory level, maybe it's a low normal level of testosterone, you do not get that benefit, and it's just that is just as bad as not treating someone at all. So if we take someone on to treat, we need to make sure that they're adequately replaced. We also have an issue that the levels of testosterone in the blood may be different in different people because of androgen receptor sensitivity, and we know there are polymorphisms within the androgen receptor, and certain individuals do have sensitive receptors and may need lower levels of testosterone in the bloodstream for biological activity, whereas those with the insensitive receptors may need to have testosterone levels in the higher part of the normal range. So I feel this whole area for management is much more complex than meets the eye, and not simplistic. So I think that research, hopefully within the next 10 years, is going to be able to sort out how we should treat, who we should treat, and what benefits we get.
And thank you very much for
I agree with that. Just to make a comment, the Sharma paper and the other studies that you quoted that show mortality benefit with testosterone treatment, we have to admit that those are not randomized controlled clinical trials, but these are retrospective studies, and they could be confounded by indication. So you cannot exclude that healthier men are treated with testosterone preferentially. And the reason for the mortality benefit is not the testosterone treatment, but the fact that they started out with better health in the first place. So that, I think it's hypothesis generating, but we do need a large, adequately powered randomized controlled clinical trial to prove that point.
Oh yes, but should we wait for those studies which are going to take years? And should people die?
It's the same question as with menopausal hormone therapy.
Yeah,
the point being that there was a lot of optimism on observational data, and then the RCTs didn't fully support the observational data. So there's a word of caution. I agree, it's a difficult decision in individualized context, but I think we should not lose the sight over the fact that there are bazillions of truly hypogonadal men that are not diagnosed because men don't get their testes examined. So that's a very important point. There's a large cohort of truly hypogonadal men that are not diagnosed because physical examination is not routinely conducted. Klinefelter's just being one example. So that's very important take-home message, to think about hypogonadism and not miss that in,
So I'd just like to thank you for bringing up the point about the androgen receptor and the CAG repeats. Hugh and I just recently had a paper published in Cardiovascular Endocrinology and Metabolism that's freely available through PubMed on the web, and it highlights exactly that point, that we need to be thinking not only about the levels of testosterone, but also about the function of testosterone in terms of how the number of CAG repeats of the androgen receptor modulates testosterone action, and therefore the downstream effects with regard to glucose handling, metabolic health, and ultimately mortality. So that paper's just out, look, CAG repeats in cardiovascular endocrinology metabolism in type 2 diabetes. So just one question for each to finish with. So a nice easy one to finish with. For Hugh, can you just remind us again about this international audit that you're doing, so that all of the delegates will be able potentially to consider inputting data to this? So question for Hugh, could you just tell us a quick headline about that, please?
Yeah, the Association of British Clinical Diabetologists have actually over the years done a lot of audit of new drugs that have come to the fore in diabetes, as well as the use of things like Freestyle Libre. So this is a study really to try and find out what's going on in clinical practice throughout the world and what the potential benefits over time are. So it's data that you basically fill in a form online or on paper first and then online, and it is collecting data on how you diagnose the condition in the first place and what levels of testosterone you base your decision on, and then you get the treatment at baseline and the follow-up over over time, really, for as long as possible, up to several years. So hopefully it will give us data on large numbers of patients that have been treated in type 2 diabetes, and be the largest study ever largest audit ever of management of type 2 diabetes in the world. And so if you can go to the website, you can read more about it, and the details can have been supplied on this account. So I think if you just go to Association of British Clinical Diabetologists, and it will take you directly to the audit page. So I encourage you to take part.
Thanks for giving us the address as well. Mathis, the T4DM study, obviously results hot on the press and now out. What follow-up is planned for these individuals as they go forward in the T4DM study?
Well, we are looking at publishing a variety of sub-studies. So on cardiovascular risk markers, lipid profile, bone health, etc. There is a follow-up study to see whether men are at risk of iatrogenic hypogonadism if testosterone treatment is stopped after 2 years, and depending on funding, a variety of observational follow-up studies that are currently on the drawboard. So it's a precious cohort, and over time more clarity will follow. We were sort of criticized by some of the reviewers that we didn't include a metformin arm, and so the argument was, how is testosterone better than metformin? But to do a study of that magnitude would have required about 10 times the men, and the budget would have been impossible to maintain. So I have to say, though, that in the diabetes prevention trial, the effect of metformin on diabetes prevention was equivalent to that of testosterone in T4DM, with the important difference that in T4DM, the benefit was actually on top of a rigorous lifestyle program, which was lacking in the metformin diabetes prevention trial. So it's very important to note that the benefits of testosterone in T4DM were on top of a rigorous lifestyle program administered by Weight Watchers.
I think it's a very good point to finish on, that actually they do the lifestyle stuff, but actually the testosterone replacement has benefits on top of that. We can never please the reviewers 100%, can we, Mathis? So I think that's a very...
we all know this, don't we?
It'd be good to hear from you and the team as we go forward with regard to the 3, 4, 5-year follow-up for these individuals. So I think at that point we can conclude. I would just like to thank my speakers today for their great presentations, but also for being so clear in answering the questions that have been put to them. I hope that this has been a helpful webinar. We've had a lot of evidence, but as always, we want clear take-home messages around the benefits of testosterone treatment in both pre-diabetes and type 2 diabetes men. As Hugh said, we need to factor in the symptom profile as well. And also we need to be patient in relation to the beneficial effects of testosterone on weight, on metabolic health, and particularly on HbA1c. But we have very good evidence presented today of the benefits of testosterone in men who are metabolically challenged, who are also hypogonadal, and that may well feed on, as Hugh said, to reductions in mortality and cardiovascular event rate. So I'd just like to thank everyone across the world for participating in this webinar. I know we've had many hundreds of people who are on this call and are still there. I sit in Salford in the UK under a slightly rainy sky. We're looking forward to spring here. I wish you a safe rest of the month. Let's see coronavirus off and look forward to meeting you again on the Andrology Research Academy webinars. And please don't forget to click on the education button to provide us with your very valuable feedback on the webinar. So it's goodbye from me. It's goodbye from Mathis. It's goodbye from Hugh. And have a really great day. We'll see you soon back in the Andrology Research Academy. Thank you so much.